Good evening, Namaskar. At the outset, I am very thankful to our Suhas Prabhu sir for accepting this invitation of AOP to deliver this very important. I always say A for antibiotics, but we should not be in any fever. Rather, A should be antipyretic, and later on we should go to how to whether to give or not antibiotic. Rather, I always say कि when you say about the antibiotic, म्हणजे अँटिबायोटिक देण्यासाठी विचार करावा फार लागत नाही, पण न देण्यासाठी जास्त विचार करावा लागतो असं माझं पर्सनल मत आहे. तर थँक्स सर, तुम्ही धन्यवाद या टॉकला तयार झालात. आणि वी नो एव्हरी पेडिशन राईट वॉज व्हेरी बिझी with all fever patients. All OPDs are flooded with the fever patients, and we know in this hardly 5% of patients may be required of that antibiotics, and so it's a so common infection, only viral, and others are different. So I just welcome all the viewers or audience on the Zoom, rather on the YouTube, for this important event of MahaUP, and I hand over mic to Amol, our secretary, and later on to Dr. Hemant, he is our president, to give her blessings for this program. And thank you very much. Dhanyawad.
Welcome all delegates again. I request President Dr. Hemant Gangulia sir to say a few words about this session.
Good evening. Namaste to our respected faculty, Dr. Suhas Prabhu sir. So kind of him to come to this session as a faculty, as well as moderator Dr. Lakshmi, my secretary Dr. Amol, state convener Dr. Jay, as well as editor Dr. Neha Singh. Yes, the topic today is all about antibodies as well as the infectious diseases. And as rightly said by Dr. J, I thought for last 2 years, our pediatric OPD there was no patient only. And we were just thinking that probably our OPD will be coming down and will never go above 40. But for now, last 2 weeks, it's almost century a day. And seeing so many patients. आणि गंमत म्हणजे फार्मा पण येऊन होते की आता सीझन आलाय आणि तुम्ही क्लॅव्हरिक ऍसिड वाला अँटीबायोटिक लिहा तर लवकर बरं होईल. असं गोष्टी होत असताना रिअली दिस इज अ टाइम वेन वी हॅव टू टेस्ट हाऊ टू रॅशनलाइज अवर अँटीबायोटिक प्रिस्क्रिप्शन. दो वी कम अक्रॉस 4 or 5 family members in a family having same symptoms, still our hands right so antibiotics, I do not know. So this is a time to learn how to come off this. And of course there's a lot of infectious diseases what Dr. Sir will discuss, as well as the rationality of the antibiotic will be more useful. So the season is back for pediatrics, and let us see how we can rationalize our treatment. Thank you very much. As well as before I end, we would like to thank Catchet Pharma to support this event. This is the 4th episode of which the Catchet Pharma has supported. We also look forward for further support for this academic support from Catchet Pharma. Thank you, Catchet Pharma. Thank you, Jay.
Thank you, Hemant sir. Today we also have moderator Dr. Lakshmi Kadu. She has done fellowship in pediatric critical care from Sion Hospital, Mumbai. She has publication in Global Journal for Research Analysis. She is the director of Parijat Hospital, which is a 17-bedded which is a tertiary care involving 17-bedded NICU and 10 beds of PICU at Amravati. She is practicing since 5 years at Amravati. Now I hand over moderator Dr. Lakshmi Bond for further session. Thank you.
Thank you, Amol sir, for your kind word. My warm regard to the President, Dr. Hemant Gangulia sir, and the Secretary sir, and all the dignitaries present over here, and of course to our eminent speaker. Today's topic is the common infectious diseases and the use of antibiotic. Now, the changing landscape of infectious diseases over the past 2 decades, we are seeing within this last 2 years that SARS-CoV has spread so much. But the childhood infections are common in the general practice. Although the clinical guidelines recommend a restricted use of antibiotic, but what we are doing in nowadays, everyone is knowing. But a big but is there that antibiotic resistance is a public threat, and this is the era of antibiotic resistance which is moving ahead, and we will be facing the complications of it. So sir is there with us to guide what we have to do and what protocol we should follow. According to WHO, the infectious diseases for the multi-drug resistance has increased so much that the 7 lakh death per year has been calculated, and across all the ages, that to 2 lakh death in the newborn only. So this is the surging issue, and we should take it very seriously. So our eminent speaker, Dr. Suhas Prabhu sir, is there with us to give us and guide us and give us the knowledge about this. There is no need of introduction to the stalwart like him. His words are less to introduce him. It is like not all the superheroes have a cape, but have some power to ignite the imagination towards his patients and care. And a sir is among them. It is not less than a superhero. So sir has bagged all his gold. Name the subject, and sir has bagged all the gold medals in every subject. Right from his from anatomy, physiology, biochemistry, means his CV is like reading 4-5 pages. I cannot name the subjects also, and even the numerous prizes and distinction he had. He's a consulting pediatrician from the PD Hinduja Hospital since 1986. More than 36 years of experience sir is having. He's an ex-honorary pediatrician and HOD at the Department of Bhabha Hospital, Mumbai. And he's a convener in a study. He's a co-author in various topics and GM on childhood TB, EPID, and AIDS. And he is in a pediatric infectious journal. And he is a recipient of 9 orations and author of over more than 50 publications are named on his name in a chapter in various books also. He's a co-editor of the textbook of Rational Antibiotic Practices, Evidence-Based Practices in Pediatric Journal. And either is like he person by the government of Maharashtra for the task force of tackling the third wave of COVID, the pediatric patients. And it was by Uddhav Thackeray, sir. So, sir, over to you. No need of introduction to you. Over to Suhas Prabhu, sir. After sir's talk, there will be
thank you, Dr.
session.
Lakshmi.
Thank you, sir. It is my pleasure.
I am a little overwhelmed that this topic on that I am to speak on common infectious diseases and how to use antibiotics is being moderated and chaired by Dr. Lakshmi. You must be treating the most difficult infections in the ICU. So I cannot even talk about those now. I'm sure she will do a better job of that. But my thanks to Dr. Hemant, Jay, Amol, all friends who have asked me to speak on this. Is a topic that is dear to me and definitely something that I would like to speak on. So my topic, as I already announced, is common infectious diseases and rational use of antibiotics. And as I told Hemant in the beginning only, I'm going to take this opportunity to talk more than what you expect. That is, what antibiotics to use in which common infectious disease. Because I do believe that we must understand the importance of using the correct antibiotic, number one. And secondly, the rationale of using a particular antibiotic for an infection. Only if we understand this, we will understand the urgency and the importance of the rest of the talk. That is, which antibiotic to use in common infections in OPD practice. And as I already said, I'm going to restrict myself to OPD practice and not really ICU cases that Dr. Lakshmi deals with. So I'm going to start with the relationship we have between antibiotics and infectious diseases. And as I said, the importance of this talk, as Dr. Lakshmi has already pointed out, because of the increasing antimicrobial resistance, we need to use antibiotics rationally. And as I just said a few minutes ago, what should be the guiding principles for choosing a particular antibiotic and using it in a clinical scenario? And then lastly, I will talk about the rational antibiotic choices in common pediatric infections. So let's start with antibiotics and infectious diseases. What is the relationship? There's something very thrilling about infectious disease, isn't it? You are like a policeman trying to catch the robber, the pathogen which is invaded the body and causing the child to fall sick. And if you look very carefully in this cartoon, what is in this policeman's hand? His weapon is the antibiotic. That is what he's going to use to subdue the pathogen. So in this cop and robber game, our prime weapons against the robber pathogen are antibiotics. So that is the importance of using them correctly. If we don't have antibiotics, we are nowhere in treating infectious disease. We are all aware that we do use symptomatic treatment when the child has an infection with whatever fever, vomiting, cough, etc. And of course, Dr. Lakshmi must be dealing day in and day out with one problem that you see with a bad infection, that is sepsis. When you do have cardiovascular disturbances and so on, which will need an ICU support. But all that is only additional. We would be nowhere if we didn't have our antibiotics. When it all started, with the serendipitous discovery by this gentleman whom you all must be recognizing, Sir Alexander Fleming, in 1928, which brought on the antibiotic era. And within a few decades, we had a number of weapons or antibiotics to play with. We had sulfonamides, which came nearly along with the penicillins. Then we had aminoglycosides during the Second World War, and further elucidation of the beta-lactams. In the 1950s, we saw chlorophenicols, tetracyclines, macrolides, glycopeptides coming in. Further antibiotic, the quinolones came late in the 60s. In our country, they came in the late 1980s. And trimethoprim was discovered somewhere in 1970s. So we got a lot of these antibiotics that we could use. So much so that this was a statement from the Surgeon General of the United States, not an ordinary man, not even just an ordinary doctor. The Surgeon General of the United States told the US Congress in 1977 that we don't need any money for any further research on infectious disease. It's time to close the book. What supreme overconfidence. Because what we are seeing now is increasing antimicrobial resistance. And this is why we need to use antibiotics rationally. Antimicrobial resistance followed immediately within a few years after the discovery of penicillin. Look at this here. Penicillin discovered in 1928. By 1940, the first bacterium showing resistance to penicillin was identified. Same for tetracyclines, even shorter interval. 1948 was the discovery time. 1953, within 5 years, bugs started showing resistance. And so on. Wherever we look at varying intervals, within a few years from the date of discovery, which you see lower down, within a few years on the top line, you see that organisms developed resistance. It was even more quickly, for example, with the fluoroquinolone. We know with what fanfare we started getting the ciprofloxacin for the so-called Dombivli fever that we saw in late 1980s. And within a few years, they stopped working. And so now we no longer use fluoroquinolones for typhoid. So you might say, like Alfred E. Newman from the Mad magazine says, what should we worry? Why should we worry? Just wait for a new antibiotic to come along. But sorry, we are going to be disappointed because the antibiotic pipeline is drying up. As is shown here, while a large number of antibiotics were discovered in the early decades of the second half of the 20th century, the pipeline has dried up in the 21st century. There are only very few new antibiotics that have been discovered. And even more alarmingly, if you look at this gray circle here, it says that there are only 4 companies worldwide that are doing research on finding new antibiotics. Companies don't want to spend money in research on antibiotics. Why is that so? And as I said, pharma has reduced its research efforts because the return on investments on antimicrobials is lower. Of course, also we know that any new drug, there is a lot of money involved in the research as well as in the regulatory requirements, which as is shown here is in thousands of crores of rupees. And the process may take up to 15 years. So, therefore, it is no wonder, as is shown on the bottom of this slide, that very few new drugs are coming on the horizon. So, we have now woken up to the fact that there is a big danger posed by resistant microbes. And we've seen these articles in the newspapers, even the Indian newspapers like the Times of India and the Hindu have spoken about this. And the UN General Assembly, not the WHO, the UN General Assembly, which is supposed to be dealing with more so-called important matters like maybe the war in Ukraine, thought it fit that they should have a session on antimicrobial resistance, because they thought that this is as much a danger to mankind as world war or a nuclear war. And this is only the 4th time in the history of the UN that the health topic was discussed in the General Assembly rather than in the WHO. Because the WHO feels that antimicrobial resistance is a serious threat to global public health. Obviously, if you have resistance, you're going to infections harder to control. Illnesses become more prolonged. Hospital stays also become more prolonged. Obviously, this is going to increase the economic and social costs of an infection. And of course, there's going to be increased mortality. How much mortality? Dr. Lakshmi mentioned a figure, which is here in the middle of this diagram. The current estimate is that 7 lakh people worldwide die every year from antimicrobial resistant infection, which we have no antibiotics to cure. And as is put here, this is possibly a low estimate. But if we look at the figure that is expected in 2050, which is less than 3 decades from now, it is expected to be 10 million, which is more than the number of patients who are going to die from cancer, cholera, diabetes, diarrheal disease, measles, and road traffic accidents combined. So this is a terrible situation that we are going to face within 2 or 3 decades. So the point is, we need to use our hoard, and I'm using the word hoard because we need to hoard them, existing antibiotics carefully, because antimicrobial resistance is developing and we have no new antibiotics on the horizon. And we have failed so far to protect our antibiotics from abuse or misuse, because we know that the primary cause for emergence and spread of antibiotic resistance is the inappropriate use of antibiotics. Why does this happen? How does antibiotic overuse or misuse lead to resistance? Now, you must have seen this figure somewhere before. I won't go to describe it. It's very, very preliminary. What is shown here is that when you use an antibiotic and you have a group of organisms, some of which are drug resistant, that is, they are resistant to being killed by that particular antibiotic you are using. Obviously, all the susceptible organisms are going to die, and only the resistant ones are going to survive, and they're going to take over, they're going to prosper. And not only that, we know that organisms transmit infections. I mean, this gene that confers resistance to antibiotics to other organisms, and therefore we're going to get spread of antimicrobial resistance all over the community. We have enough epidemiological studies that show that there's a direct relationship between antibiotic consumption and the emergence and dissemination of resistant bacterial strains. And what is the story in our country? This diagram shows you the amount of antibiotics that have been used. And we use the term daily drug dosage. I am sure you are aware of this. It's a common term for those who are familiar with antimicrobial stewardship. Per 1,000 population. And you can clearly see that in the last 15 years, this chart unfortunately goes only up to 2015. The amount of antibiotics that have been used have risen tremendously. Look at the blue lines. This is the broad spectrum penicillins. They've gone up almost double. And very importantly, the cephalosporins has more than quadrupled from less than, say, 400 or 350 DDD per 1,000 population. It has gone up to almost 2,000. So it's increased more than 5 times. Now, I don't think India's population has gone up 5 times. And in fact, with sanitation, immunization, and other improved hygienic measures, we've actually managed to reduce the incidence of infectious disease. So this clearly tells us that something is wrong. We are using too much of antibiotics, and obviously it is inappropriate. So having discussed this issue and clearly faulting ourselves for overusing antibiotics, let's say that we are going to use antibiotics. Yes, we have to, but we have to use them very carefully. So we need to clearly understand what are the guiding principles for using an antibiotic. The first thing is, of course, that never write an antibiotic without proper thought. The word rational means after thought, after a reasoned thought. So therefore, we have to think before we write an antibiotic, and we have to consider the choice very carefully. Obviously, we know that antibiotics are to be used only when we are reasonably sure that it's a bacterial infection, not otherwise, because antibiotics do not work for viruses. They do not work for parasites. They do not work for fungi. Of course, we have other drugs that we use which are of similar nature, which we refer to as antimicrobials. Yes, they're all one group. But antibiotics, we know, are specifically used for bacterial infection. So when you have a viral or a non-bacterial infection, antibiotics should not be used. So what is the guiding principle? The guiding principle is to use targeted therapy. So now when you want to give a targeted therapy, first of all, you have to identify the target. So you have to identify the target pathogen, and you have to make an effort to do so. No patient comes to you with a pneumonia where you can examine and say, oh, I can see Streptococcus pneumonia in your lung. You cannot. You can see the pneumonia, but you don't know which is the organism. Of course, the gold standard is cultures, but we can't always do cultures in every case, and they may not be always positives, especially, for example, in a pneumonia or something. In sepsis, yes, very often we get. In bacteremia, we get. In meningitis, we get, but not in many other infections. But there are other methods of identifying the target, the pathogen. We can look at smears. We can clearly see what is a gram-positive cocci in clusters, and we say, yes, this is Staphylococcus. We now use increasingly commonly non-culture methods for identification, the molecular methods, identifying the bacterial DNA or the RNA. There are very few RNA bacteria, but I put the term here because we also use it for viruses. We can look for the part instead of the whole. We can identify the antigen or a part of the capsule. We can look for the body's specific immune response to the virus by checking the antibody titers and say, yes, this antibody is against this particular organism, and therefore this patient must be having this particular infection. And of course, we have specific radiological and histopathological changes that can tell us that this is likely to be a particular pathogen. Like you do a histopathology of a lymph node, and then you say, okay, I can see caseation, I can see Langerhans giant cells. Then even if you don't see the AFB, you know that this is most probably TB. So we have so many methods of identifying the pathogen so that we can give targeted therapy. Now, in spite of all these methods, we cannot always identify the pathogen. But if you can't identify the pathogen, we need to guess. But the guess has to be rational. And when we do this, we call this empiric antibiotic therapy or empirical therapy. Now, let me tell you how empirical antibiotic therapy is done. I'll give one simple example. You have a patient with acute otitis media, community acquired. I'm not talking about a child who's got immune deficiency, somebody who's got some kind of anatomical abnormality in his middle ear, he's got a cleft palate. Oh, chodo. A simple, sada, acute otitis media, community acquired comes to you. And like I just told you, acute otitis media is not a condition where you can very easily do a culture. Yes, you can do a tympanocentesis, draw the middle ear fluid, send it to the culture. But it's not a procedure that can be very easily done. So we don't often do it. Even our ENT surgeons are not really willing to do it in a small child. So this is a kind of situation where you have to do empiric therapy. Now let's come to this thought process. Suppose the thought comes in our mind that this patient, suppose I treat with amoxicillin. Is it going to work? So this is the thought process, the rational thought process that needs to come. So the first step to decide whether amoxicillin would be a good choice for this patient is to list the causative organisms that commonly cause a community-acquired acute otitis media in an immunocompetent patient. So you look up this data, and we know that this is the pattern that we see. Now this is data from the All India Institute in Delhi. I believe this is from Dr. Kabra's paper. But anyway, it's very similar wherever over the world you look. About a third are viruses, almost between 1/3 and 1/2 are strep pneumoniae. Then we have about a fifth are H. influenzae, Moraxella catarrhalis, about 12%. And the others are very, very small in number. These three organisms, bacterial organisms, strep pneumoniae, H. influenza, and Moraxella catarrhalis, constitute the large majority of bacterial infections. So now you put your mind to the thought process and say, okay, suppose I treat this patient with amoxicillin. Will it work? How many of these organisms will die? For that, you need to know additional information of what is the current sensitivity of this particular organism to this particular antibiotic in your area. And if you look up that data for India, this is the answer that you will get. Of course, viruses will get cured anyway because you don't really need the antibiotic. Current strep pneumonia sensitivity to amoxicillin is about 95%. So of this 35%, 33% will get cured. I mean, of the total, 95% of 35% is 33%. Same way, 60% sensitivity to H. influenza, 40% to Moraxella. You do the mathematics and you'll find this is the number, percentage of patients are going to get cured. So you just total it up and you'll find that this number is now 82%. So I have my answer that if I use amoxicillin without identifying the target pathogen, I have not done a culture, I have not done a smear, I have not done anything. Just from my knowledge of what is the causative pathology of otitis media in the community, I know that if I use amoxicillin, it will work in 82% of cases. So if you want to use any other antibiotic, you have to run this algorithm in your mind. Suppose you say, okay, I want to use cloxacillin. See what will be the sensitivity of strep pneumonia, H. influenza. You want to use, say, azithromycin. Run this through your mind. And you will find that among all, amoxicillin is still the best choice because it has the success rate of 82% based on this data. Now the thought may come into your mind, are 82%? That means 18% of my patients are not going to get better. I need to use something that will cure all 100% of them. Now remember, this is not possible really. If you want to cure 100% of your patients who come to you with acute otitis media, you will have to probably use vancomycin with meropenem, with clindamycin, with possibly some other antifungal agents too. But we don't need to do this. We should be aware that for milder infections that we see in our outpatient practice, the dictum is that it is adequate to use an antibiotic that will succeed in at least 0.75% of cases. 75 to 85% is good enough. Why? Because if you start using antibiotics that are going to cover 95% of patients or more, you will end up using stronger antibiotics, which are unnecessary in the large majority of patients. These 85% or 82% have been cured by amoxicillin. In order to cure the additional 10% by amoxiclav, for example, or by ceftriaxone, or by linezolid or whatever, you are unnecessarily subjecting 82% of the children to this broad spectrum antibiotic and therefore induce resistance to that antibiotic. So that later on, when you really need it for a resistant organism, it will not be available to you. Is this clear? We also have the ability that if the patient does not clinically respond to you, in say 48 to 72 hours, you call him for a follow-up, then you have a chance to change to the second line drug. However, in severe infections, like the child in ICU that Dr. Lakshmi might be treating, I'm not suggesting 75 or 80%. You will probably need a broader coverage to cover 95% of your patients. So, once you have identified the pathogen, the trick is to use the single narrow spectrum antibiotic, which is effective for this particular pathogen that you think the patient has got. Single or maybe a couple of pathogens like we said in this patient. Why would you want a narrow spectrum antibiotic? Because it has the least toxicity, least cost, least chance of inducing drug resistance, and least chance, of course, of causing super infection with a multi-drug resistant organism. If you simply put every patient on meropenem and he's going to develop drug resistance, what is he going to develop resistance to with? He's going to develop a carbapenem resistant organism, gram-negative organism. Then you have to give colistin. So that's not a great idea. So let's use simpler, less spectrum antibiotics, narrow spectrum antibiotic, so that we have something left in reserve for these patients who will not respond at the end of 48 to 72 hours. Now, having covered that basics, which should make it really very clear to you why we need to be very careful in using our antibiotics and what is the rationale or the thought process in choosing the antibiotics, I'm now going to come to the main part of my talk, and that is which antibiotics to use in common pediatric conditions. And I know I have only half an hour left more, so I'm going to cover only 5 groups of conditions, and these are the ones that we're going to treat on an outpatient basis. I'm not going to talk about patients that we're going to treat inpatient. Okay, so let's start with URTI, which is one of the commonest things that we see. When to start antibiotics and which is what I'm going to discuss. But before we go into that, we have started off on the wrong foot. URTI is not a diagnosis. URTI is a conglomeration of conditions of varying etiologies. And sometimes we even refer to allergic rhinitis or mistakenly diagnose an allergic rhinitis as a URTI. So we need to be very careful. We cannot label a patient as URTI. URTI is not a diagnosis. It is important to make and write down a specific diagnosis. So what is the specific diagnosis? What are the specific diagnoses or clinical syndromes that we encompass in the term URTI? And they are listed here. I'm not going to talk about the LRTI, although we do treat some of the LRTIs on OPD basis simply because there's not enough time. Yes, we treat bronchitis on OPD basis, and a small pneumonias also in a child who is not very sick. You can treat on OPD basis. But I will restrict my talk today to URTI. So we have coryza, which is rhinitis, pharyngotonsillitis, cru, which is involvement of your larynx, epiglottitis, which is inflammation or infection of your epiglottis, otitis media and the surrounding paranasal tissue, which hollow tissues, which we call the paranasal sinuses, and the mastoiditis, which is a continuation of the middle ear cavity. These are what constitute the URTI. So you have to clearly label in your mind after examining the patient and write this diagnosis down on the paper, what your child is suffering from. URTI is not a diagnosis, I repeat. And are antibiotics required for all URTIs? No. A large number of respiratory infections are viral. And of the URTIs, by far the vast majority are viral. So they don't need antibiotics. And as I said earlier, we mistakenly call many other conditions, non-infectious conditions, as URTI. Many children who have come to you with cough, cold, sneezing are not infections at all. They're simply exacerbations of allergic diathesis or allergic rhinitis and bronchitis. And one of the first things you should do is that you make sure you document fever before even thinking of using an antibiotic, because we know that allergies do not cause fever, infections do. And I go through a small list of choices of antibiotics for respiratory pathogens. And remember, I told you earlier, you have to think what is the pathogen, what is the target before you decide the antibiotic. So these are a list of the 5 common organisms. And remember, believe me, these are the only 5 that are going to cause the vast majority of URTIs that you are going to see, the entire group. Whether it's the rhinitis or the otitis media or the pharyngitis or whatever. इसके आगे नहीं है. 95% are all these or maybe more. So your first choice antibiotic for the first 2 strep, whatever species, is amoxicillin. For Haemophilus and Moraxella, it's amoxiclav. Of course, Staphylococcus requires anti-staphylococcal penicillin, of which the representative one is cloxacillin. But we also know that a first generation cephalosporin like cefotroxil will work for the same. These are your first choice antibiotics. Now look at this list. What does it tell you? It tells you that for URTI, you should use only 3 antibiotics as the first choice. Amoxicillin, amoxiclav, or cefotroxil. I'm saying cefotroxil because cloxacillin is not easily available. If it is, there's no harm in using cloxacillin. And what do we see people writing? I'm so ashamed of colleagues who write anything beyond this, which are the obvious first choice for an antibiotic. I can understand your patient who's you given this, it does not respond. Yes, you have alternative choices, and they are listed here on the side. But these are never first choices. Strep pneumonia can be treated, of course, with cephalosporins, macrolides, erythro or clarythro, not azithro. Hemophilus will respond to cefuroxime or a macrolide, so also Moraxella. And Staphylococcus, of course, we use linezolid. And I've not listed vancomycin and others because we are only talking about outpatient. But you have to prove MRSA before you can write linezolid. So next, from tomorrow onwards, in your OPD prescription for an URTI, you're going to write only 3 drugs, only 3 drugs, only 3 drugs, antibiotics. Amoxicillin, amoxiclav or cefodox. Or koi nahi hoga. I'm not going to even take names of any other antibiotic that people write. Okay, let's come back to this list. Now you see that 2 of the syndromes are put in red. Why are they in red? Because that's the red zone for antibiotics. They are viral. We don't use antibiotics in rhinitis and we don't use antibiotics in croup. But we do use antibiotics in pharyngotonsillitis, but not in all cases. Now we know that pharyngotonsillitis can be viral or can be bacterial, but it can be very difficult to distinguish. I put 2 photographs of throats of children here, and I may ask you to guess. I know this is not an interactive session, but please guess in your mind which one in your mind you think is viral and which you think is bacterial. I'll pause for 5 seconds. Okay, I hope you thought in your mind, and I can give you the answer now. You might be surprised that this is the one which is Streptococcus and this is the one which is a virus, which is EBV. This is the membrane that you see with the EBV, and you can confuse this for a purulent tonsillitis. So, how do we make out it's viral or bacterial? Not just by looking. We have to go into the history. Acute bacterial pharyngitis, high fever over 101, sudden onset, sore throat. There are associated symptoms like headache, nausea, vomiting, abdominal pain, patchy, discrete exudate, marked inflammation, tender, enlarged anterior cervical node, not the ones in the posterior triangle of the neck. And of course, the seasonal incidence. Whereas if these features are absent, it suggests of a viral etiology, and many viral infections of the pharynx or the tonsils will be associated with conjunctivitis, coryza, running nose, cough, and diarrhea. How common is bacterial tonsillopharyngitis? It's only about 30%. And almost every case of bacterial pharyngotonsillitis is caused by this single organism, the group A beta hemolytic streptococcus. We also know that it's most common in children between 5 and 15 years of age, less common below 5, and also less common in adults. And very important for us, we also know that this is that particular age group where you should think of streptococcus, because if you don't treat it in time, you can end up with rheumatic fever. But what is the corollary? The corollary is that if it's less than 5 years, don't worry about streptococcus, don't even give an antibiotic. Remember, while this is a bacterial pharyngitis, it is a self-limiting condition. The reason why we treat in this 5 to 15-year age group is, of course, to prevent complications. Very occasionally, streptococcus can cause a bacteremia, can cause sepsis, can cause a paratonsillar abscess, and so on. But most of the time, in a healthy immunocompetent child, group A beta hemolytic streptococcus, sore throat, or pharyngitis is a self-limiting illness. Even if you don't treat, they get well. But we are worried about rheumatic fever, so we would like to treat. Okay, so how can you predict which is bacterial? You look at a clinical scoring system, and this can avoid the need for doing cultures so that we don't overuse antibiotics. Now, the standard score that we use, the clinical score, you must be knowing this is the Centaur score. There are 5 things you look at, they're listed here, 1 point for each. Absence of cough. Remember, I told you presence of cough is viral. Swollen and tender anterior cervical nodes. Temperature above 102, which is about 38 degrees. Tonsillar exudate or swelling. And as I told you, the school age group. If any of these are present, you're going to give 1 point for each of this. So you have a score ranging from 0 to 5, 1 for each. Okay. Now, you do this total, and depending on the score, you will decide whether to give antibiotics or no. If your score is 0 or 1, your risk of group A beta hemolytic streptococcus is less than 10%. You can just wait and watch. If the score is 4 or more, 4 or 5, of course, the maximum is 5, there are only 5 points. The risk of group A beta hemolytic streptococcus is over 50%, and you can consider empiric treatment even without doing any test. But when you have a score of 2 or 3, you need to perform either a throat culture or a rapid antigen detection test. And if it is positive, treat with antibiotics. If negative, you don't treat with antibiotics. This should be your protocol. And this is the rapid antigen test. It's a strip test which you should ask for in your town or zone or village or wherever you are working. It is available in India. It has been validated in India by one very excellent study which was reported by Dr. Bala Subramanian from Kanchi Kamkoti. So it works even in our country. It tells you whether it's strep or not. We say it is not available because we don't ask for it. I think we underutilize it. And while you may think it's expensive, I think it costs a few hundred rupees. It is not more expensive than the high cost of developing antimicrobial resistance. So we should be using the rapid antibody and antigen detection test. So what are the choices once you have diagnosed it as a bacterial tonsillopharyngitis? I already told you, it has to be amoxicillin. You can also use penicillin. But the problem with penicillin is that it's not easily available. And while penicillin G will work, if you give it orally, we know that it's destroyed by stomach acid. So you need to have an acid-resistant penicillin, what we call penicillin V, which is not available in our country. But you can inject benzathine G to a patient, and you can even give a single dose of benzathine, and this will work to cure the patient of streptococcal pharyngotonsillitis. Cefpodoxime can be used for 5 days, not my choice. I stick to amoxicillin. This is the drug I use. You would use a macrolide only if it is allergic to penicillin. The other drug is clindamycin that you can use. Now, if you have a younger child, remember a small percentage of cases can be due to staph. If the child is toxic and seriously ill, you should cover for staphylococcus. So this is the patient who might opt to use additionally cefadroxil or cloxacillin or even move to an injectable. Cru is viral, so it is in red, no antibiotic. Epiglottitis presents like cru. This is cru. Sudden nocturnal onset, you must have seen this, a barking cough, hoarse-wise. Patient has hardly any fever and the throat looks benign. But epiglottitis can present similarly. But the child, on the other hand, has high fever, toxic look, he has odynophagia, he doesn't swallow. So he has drooling and a severely inflamed throat. What is the organism? H. influenza. So what is the antibiotic? Remember the chart I showed you, amoxicillin. Then I come to acute otitis media. Remember, it's to be diagnosed only by doing an otoscopy. You cannot say otitis media because the child is tugging his ear or is crying because you think he has ear pain. Make it a habit to use an otoscope. This is what acute otitis media looks like. This is what a normal eardrum looks like. They're very clearly different. And only if you have diagnosed an otoscopy in acute otitis media, you will opt to use an antibiotic. Now, this you're going to do even without doing a tympanocentesis or whatever, although we know that there are some viral, but this percentage is only about 30%. Unlike tonsillopharyngitis, where 70% are viral, here only 30% are viral. And these are the organisms. Remember, I showed you that percentage chart where we work whether amoxicillin work. These are the 4 organisms that I mentioned there. And the antibiotic choices, of course, are amoxicillin or amoxiclav. These are the options, but they are not my first choices. And of course, if you have a very sick patient or a very young child, we would admit, say below 6 months, for example, acute otitis media deserve admission because you're worried about intracranial spread. And then, of course, you'll use an injectable cephalosporin or so on. Macrolides are not a great choice for acute otitis media because they do not penetrate well into the middle ear fluid. And if at all you have to use a macrolide, remember to use a macrolide that has more gram-positive coverage rather than gram-negative coverage. In other words, your drug, your macrolide of choice has to be clarithromycin and not azithromycin. When do we use an antibiotic? Of course, the diagnosis has to be established by symptoms, physical examination, and otoscopy. And I quote from the AAP, AFP guidelines. The reference is given at the bottom. Below 6 months, yes, we treat all patients, and some of them are sick. As I said, we admit and treat. But coming to the outpatient treatment above 6 months, you should treat if there is autoria or there are severe signs and symptoms. What do you mean by severe signs and symptoms? Fever above 102.2, ear pain lasting for more than 48 hours, or severe otalgia. These are your criteria. If you see them, treat. Antibiotic 10 days therapy. 6 to 23 months with bilateral AOM, even without severe signs, 10-day antibiotic. 6 to 23 months, if it's only on one side and doesn't have the severe sign that I've listed above, then the recommendation is to wait for 48 hours with symptomatic treatment, nose drops, steam inhalation, and see whether the patient responds. And if he does respond, he does not need an antibiotic. About 24 months of age, if there are no severe signs or symptoms, the dictum is observation, or you may use an antibiotic after waiting for 48 hours. But this is a shorter course of 5 to 7 days. So remember, this is the way we have to use antibiotics for acute otitis media. What about sinusitis, which often may be associated with purulent rhinitis? So that is this term here. You see ABRS, don't get confused. Is the standard term that has been coined by the Infectious Disease Society of America. And it refers to acute bacterial rhinosinusitis. That is what ABRS stands for. And many patients with sinusitis, you see this thick purulent nasal discharge, which is why we call it a bacterial rhinitis. Now, remember that sinusitis is rare below 5 years of age. The organisms are the same as for AOM, so therefore the treatment choices are the same as for AOM. I've listed them on the previous slides. I'm not going to go into it again. But remember that we need a longer course, 2 or maybe even 3 weeks and not 10 days. And sometimes you need surgical training, so you have to call in your ENT colleague. How do you diagnose or make a clinical diagnosis of ABRS? Nobody is saying you need to do CT scans. And it's become a very favorite now to do what they call limited PNS CT. You don't need to do it. It's a lot of radiation to the developing brain in a small child particularly. Don't do it at all. You don't even need a simple X-ray. Diagnosis of ABRS according to IDSA 2021-12 guidelines is clinical. 1, persistent not improving disease more than 10 days, severe symptoms or signs of high fever above 39 degrees and a thick purulent nasal discharge, or facial pain over the sinuses, either on the mastoid or here on the frontal region. And remember this, after 5 years of age, we don't see sinusitis, at least not mastoid and frontal sinusitis below 5 years of age. If the pain lasts for more than 3 or 4 consecutive days at the beginning of the illness. And lastly, we have something called double sickening. That means you have a child who presents with a viral illness. He has some high fever, little running nose. We see so many of them now, as Dr. Hemant said right at the beginning. They seem to improve for 3-4 days. And then towards the end of 1 week, they come back with a worsening of symptoms. So this is what you call double sickening. There's an illness in the beginning. There's an afebrile period or a well period of 2-3 days. Then this is a secondary bacterial infection. So now read between the lines. You cannot diagnose sinusitis clinically unless 10 days have passed. Unless the child has fever above 39 degrees with a thick purulent discharge and facial pain over the sinuses lasting for 3 or 4 consecutive days. This is the clinical diagnosis of sinusitis. You can't just label anybody as sinusitis and give treatment. Okay, now we leave the respiratory infections and come to GI infections. A common situation, we see an 8-month-old female weighing 8 kilograms, loose stools for 2 days, watery greenish yellow stools. The mother says she's documented a fever of 101 degrees Fahrenheit. The child has vomited twice. You examine, you find dehydration, you do a stool examination. WBC 5 to 6 per high power field and a couple of RBCs per high power field. Which antibiotic to give? The answer is none. But before we go to that, you should ask yourself why you did the stool examination. Stool examination is not routinely indicated in acute diarrhea. So not required at all. You only manage to confuse you because you see these pus cells and the few RBCs, then you start thinking it's a dysentery. This is not dysentery. Dysentery on the stool examination is large amount of red blood cells and sheets of WBC trapped in mucus. This is bacillary dysentery report. Or visible blood to the naked eye. This stool report is not dysentery. This you will see in any diarrhea. So few WBC and RBC do not indicate an invasive infection. It is likely to be some viral infection like rotavirus, maybe an adenovirus or some other virus, or enterotoxigenic E. coli. Because there is no visible blood in the stool, this is not Shigella or any invasive Salmonella. This is self-limiting, no antibiotics. What do? ORS, zinc, and continue feeding. No antibiotics. So when do you give antibiotics in diarrhea? When there's bloody diarrhea, or you have amoebiasis, giardiasis. Of course, here we don't give antibiotics. We give other antiparasitic drugs or antimicrobials. Cholera, diarrhea associated with systemic infection, or if the host is immunocompromised. This fourth column is something we call parenteral diarrhea. When you have a child with sepsis, a young child, particularly an infant or neonate, can come with diarrhea when actually you will find bacteremia in the blood. If you have to use, which antibiotic do you use? The WHO's website talks about using ciproflox or norflox, but this is, is not approved by the DCGI, Drug Controller General of India. So therefore, I don't use these at all. My first choice is either cefixime or cotrimoxazole. I reserve erythromycin as I think it's a very important drug for other infections like multidrug resistant typhoid and so on. So I don't use erythromycin. My drug for bacillary dysentery is cefixime orally. What antibiotics are not indicated for bloody diarrhea? Furazolidone, first and second generation cephalosporins, aminoglycoside. How often I see patients get injection amikacin for diarrhea? Doesn't work. Colistin doesn't work. Sulfonamides don't work. Should we use metronidazole? Yes, for amoebiasis, or of course for necrotizing enterocolitis, but we are not talking about that here. We're talking about simple infections. Remember that amoebiasis is difficult to diagnose by routine laboratory infection, but it's very uncommon in young children. It's less than 2% of diarrhea in children under 5 years of age. So I would use anti-amoebicidal drugs only if the microscopic examination of fresh stool done in a reliable lab shows trophozoites of E. histolytica. I'm saying it first, but I put it second because this is very difficult to do in practice. So what do I do? If I'm not sure whether it's bacillary or amoebic dysentery, then if two different antibiotics that are usually effective for Shigella, which is your commonest cause for bacillary dysentery, are given one after the other and the patient does not respond, then I can think that it might be an amoeba and then use an anti-amoebicidal drug. Now I'm coming to SSTI or skin and soft tissue infections, what we commonly call pyoderma. Now again, like pyoderma, if you label somebody as pyoderma, you're not using your brain. Pyoderma, like URTI, is a heterogeneous group of conditions. You need to identify the layer of the skin or subcutaneous tissue that is involved in the infection and treat accordingly. The commonest pathogens that cause skin and soft tissue infections are either staph or strep. These again account for over 95% of your skin and soft tissue infections. And here, of course, you can consider using local antibiotics alone or in combination with systemic therapy. Now, this is a chart that shows you might have seen this picture of the various levels of the skin and infection thereof. The topmost layer is impetigo. Infection of the lymphatics is erysipelas. Folliculitis, furuncles, carbuncle is this middle layer of the skin, the deeper dermis. And then lower down, you have these abscesses. And when the fascia is involved, we call it necrotizing fasciitis. So depending on which portion is involved, You have to write the diagnosis. Just like you can't write DRTI, you can't write pyoderma. You have to write folliculitis. You have to write impetigo, or you have to write cellulitis. Then only you can write the antibiotic. Now you will say, how do I know? Dr. Prabhu shown a nice picture with cut layer of the skin. Am I going to do skin biopsy in every patient? The answer is no. The diagnosis of all pyodermas is by their characteristic appearance. And therefore, the diagnosis is almost always clinical. Look at these pictures. This is impetigo, involving only the superficial layer of the epidermis. And there are two types, where you have bullae, we call it bullous impetigo. Otherwise, we call it impetigo contagiosa. How do you treat impetigo? Local treatment alone. Why? If you remember that picture that I showed you earlier, this is the epidermis. Your blood vessels are here. Giving an oral antibiotic is not going to reach here. You apply a local antibiotic here and it will reach the organisms that are there. So impetigo is treated with oral antibiotic. These are the antibiotics that we use, so not orally, local antibiotic. Mupirocin is the drug of choice. You can also use fusidic acid, nadoxin, retapamilin, it should be, misspelling, ozenoxacin. But my choice is mupirocin. I still find it works well. Although the MR who comes and details these three antibiotics, you will say, oh, now we are seeing resistant to mupirocin. I've not really seen it in my practice. When will you use systemic antibiotic for impetigo? Only if there's a bullous impetigo, because then there's a possibility of systemic spread, or if there is widespread lesion, suppose a lesion on the hand, on the buttocks, and somewhere at the third place, then you would think that there's probably a bacterium and that is how it has spread. And also we are worried when you have impetigo in the perioral region, because we know that here you have what we call penetrating veins, which can communicate with your intracranial sinuses, and that might spread there and cause a problem. Erysipelas looks like this. It is infection of lymphatics with linear centripetal spread. They require systemic antibiotics because the lower layer of the skin. Deeper dermal infections look like this. This is a furuncle. This is, of course, cellulitis. Often there is quite severe pain and tenderness, and there's almost a rupture, an ulcer, or a wound and a discharge. And this, of course, is what an abscess looks like. You know what this looks like. And all these patients, because the deeper layers are involved, there is some amount of toxins carried into the blood. Sometimes there's even bacteremia, and therefore you will have systemic symptoms present. And therefore you need systemic antibiotic. But this does not mean you neglect the local area. Moist sheet application, IND of an abscess is a must. For a furuncle, you can simply pluck the affected hair. Systemic antibiotics are required. What will you use? The ones that cover staph and strep. So usually cefadroxil or cephaloxin alone is adequate. Comoxiclav may also be used, and only rarely if the patient is very sick, you're going to use injectables. Local antibiotic creams you may of course use additionally, but only if there is a wound. If the skin is unbroken, they're not going to work. What about UTI? The diagnosis of UTI is difficult in young children because the symptoms are not so easy to elicit. But of course, we should not miss it. We need to do a routine urine examination in all kids when there is no focus in a short duration fever. If the urine is showing pyuria or the equivalent, that is a positive leukocyte test, and or particularly a positive nitrite test, this is highly suggestive of an infection. We need to confirm desirably by culture, because we know that pyuria without a positive nitrite test can have a lot of non-infective causes. It can be glomerulonephritis, it can be due to a stone, and so many other conditions. It can be also due to any fever. Any high fever can cause some pus cells in the urine. It can be caused by Kawasaki and so on. So there are lots of conditions where you will see pus cells in the urine alone. So don't go by that. But you may start antibiotic without waiting for culture if all these three are present: fever plus urinary symptoms plus nitrite positive in a patient with pyuria on routine examination. What are your antibiotic choices? Cefixime, drug of first choice again. This is the dose. Cotrimoxol I still like to use. Amoxicillin or amoxiclav is often effective. And I put this here because you might have started it thinking the child has got a pharyngitis, and then the child comes back after a day with a urine report showing pus cells. You don't necessarily have to move from amoxicillin to cefixime because it's UTI. This drug might still work because these are concentrated in the urine. Norfloxacin, ofloxacin are not permitted by our authorities, so and they're often not effective. I find a lot of drug resistance when you do culture to these two antibiotics, so I don't use them. So this is what I use. So now if you go back to my list, you'll find that Dr. Prabhu uses only 4 or 5 antibiotics in his OPD practice. His OPD prescriptions are only amoxicillin, amoxiclav, cotrimoxol or cefixime and cephalosporin. इसके आगे छठवां एंटीबायोटिक मैं लिखता नहीं हूं, very frankly, and I don't see any reason for you to write it, not as a first choice. These antibiotics are not suitable for UTI in children because nitrofurantoin does not really penetrate into the kidney tissue, not useful for pyelonephritis. Chloramphenicol, azithromycin are not excreted in the urine, so not a good idea. And lastly, I'm going to take a couple of minutes to talk about treating enteric fever. Can you treat enteric fever on OPD basis? Yes. If the patient is not very sick, you can. How do you make a clinical diagnosis? Because of course you need to do a culture, but that will take 48 hours. If the patient is coming from an endemic zone, there's a history of exposure, he's gone and eaten pani puri somewhere, step ladder pattern of fever, marked anorexia, nuchal headache, the coated tongue, no respiratory symptoms really, hepatosplenomegaly, and we have a normal CBC, positive CRP. This is really highly suggestive of enteric fever. And as I said, you can treat these patients with oral antibiotics if the child is not toxic and is not vomiting. Which oral antibiotic? Cefixime, cotrimoxol, azithromycin, again, not first choice. So again, I don't have to go beyond the 5 antibiotics that I've listed for you. इसके आगे use नहीं करने का. I have medical reps who come and give me samples of, God knows, I don't even remember the names of oral 3rd generation cephalosporins, and they lie in my drawer. I tell them, please don't give it to me, I'm not going to use. And they say, no, 2 bottles rakho, and they expire and I throw them away. And this should be your condition in your clinic. I don't see any reason why you should use those antibiotics in your routine OPD practice. However, when you use oral antibiotic for enteric fever, you need to watch out for complications, watch out for vomiting. If the patient is deteriorating or having a complication, not retaining the antibiotic, yes, you need to admit and give him injectable antibiotics. So remember, when we use antibiotics, we need a careful approach. We need to avoid misuse and overuse. We need a dual focus. We need to, of course, our patient to recover. We want a good clinical outcome, but we also need to use antibiotics optimally. So this is what we mean by antimicrobial stewardship. Who needs to do antimicrobial stewardship? Not only the people who work in the hospitals, not the people who work in the ICU, all of us. And every one of us should do this. And if we do it, we can make a difference. But all of us, every man, must try. John F. Kennedy said so. And I do believe that it is true. We must try, all of us, all the time, to use antibiotics rationally. Thank you very much.
Thank you very much, sir. Sir has covered each and every aspect what in regular OPD, right from acute otitis media, tonsillopharyngitis, croup, epiglottitis, AOM, sinusitis, and UTI, enteric fever. In just in 1 hour, you have given us a guideline what to use and what to not. And you have restricted us to use for only amoxicillin, only cefixime. There is a nowhere you have given a guideline for azithromycin, which we are using
azithromycin in OPD practice.
Yes, and that is what most of the pediatrician are using rampantly. Azithromycin is on the verge. And nowhere there is a metronidazole, nowhere norfloxacin, ofloxacin. And these things we are facing in ICU, that is a multi-drug resistant because of the use of all these by the GPs, from the BMS doctor to the pediatrician. So we must take a pledge now that we should restrict ourselves to these antibiotic only, not moving ahead. And if we are moving ahead in our routine heavy OPD, then we should justify it because there is an era ahead and we need to save those children ahead also. The sir has already shown us how the burden is increasing, and by WHO, by 2015, 10 million deaths it has given that the 10 million death can be there because of just a multi-drug resistance era we will be facing. So thank you very much, sir. Any questions? In chat box, there are no questions right now.
Sir, I would like to ask you one thing, sir.
Yes.
As azithromycin is reserved for the as a second line drug for this tuberculosis, if we use macrolide as an erythromycin or the clarithromycin, does it give cross resistance with azithromycin to azithromycin?
No, not really. There's no cross resistance. So it's safer to use. Of course, the role of macrolides is still very restricted. I mean, as I said, it doesn't even come in my list of 5 antibiotics that I love and that I prescribe. Usme erythromycin, clarithromycin nahi aata hai. I listed them. I'll say them again. Amoxicillin, amoxiclav, cifadroxil, cotrimoxazole, cefixime. Clarithro is rare. It's not the first choice anywhere.
Yes.
And azithro is not there at all.
One more question, sir. Because we see, it is a very rare rare side effect of cotrimoxazole is Stevens-Johnson syndrome.
Yes.
Does that create a fear in the mind, looking at the medical aspects and all these things? If someone develops Stevens, because I also like cotrimoxazole very much, I was using, but that fear has come set in regarding this. What is your experience about it?
You need certain precautions. I would always ask before I prescribe for the first time to a child, is there a family history of allergy to sulfas?
Okay.
Is the sulfa component that you're allergic to, not trimethoprim? So sulfa allergy is one thing to ask. Of course, ask whether the child has had sulfa allergy in the past. That's your question number 2. Point number 3 is you tell the parents that in case the child gets rashes, inform me and stop immediately. These are the 3 things you do. And if you do that, I think you're pretty safe. It's not that common also. And if you get the rashes, you stop immediately. It doesn't really progress to a full-fledged Stevens-Johnson syndrome. If you don't recognize it in time and continue, that's when you get problem. So I think we need to take these precautions when you prescribe cotrimoxazole.
Sir, can I ask a question?
Yes, Dr. Sushma.
Yeah, thank you, sir. Sir, what about bone marrow toxicity or suppression by cotrimoxazole?
That's very rare.
Acha.
It does happen, but it's extremely rare, even less than Stevens-Johnson.
Okay.
I would worry about bone marrow suppression more, for example, with chloramphenicol. That's
Yes,
much
sir.
more common. 1 in 40,000
Yes,
or 1 in 50,000 is the figure. Bone marrow
Yes,
suppression
sir.
with cotrimoxazole does not happen in routine patients.
Okay, sir. Sir, and one more thing. What about resistance to cotrimoxazole in bloody diarrhea, sir, dysentery?
Yes, you do
Because,
see
yeah.
resistance. I'm also seeing occasionally resistance to cefixime, but not that commonly. My first choice is still cefixime, but I do use cotrimoxazole if I've seen that the patient has received cotrimoxazole in the past. There are several reasons why I prefer cotrimoxazole if I can. One is I would like to spare cefixime, because while Dr. Hemant asks a very vital question whether there is cross resistance between macrolide, the answer is no, but there is cross resistance between 3rd generation cephalosporins. If you are exposed to cefixime, you will develop resistance to ceftriaxone or cefoperazone. And now Dr. Lakshmi will have major problem when the patient comes with sepsis, because the child has received several courses of cefixime and now ceftriaxone is not going to work. So that's point number 1. Point number 2 is cotrimoxazole is a very rapidly acting agent. It's a bactericidal much faster than cefixime. We all know how long ceftriaxone takes to cure typhoid fever, whereas cotrimoxazole works much faster. It's bactericidal. So that's the second reason. The third reason, of course, is the fact that cotrimoxazole is an exceedingly cheap drug. The problem is much cheaper than even cefixime. But the problem nowadays really is that cotrimoxazole syrups are not easily available. So that restricts the use, and therefore I use cefixime in many cases.
Thank you, sir. Thank you, sir.
Sir, this penicillin is available as an oral pentates. What do you think of its use in pyodermas or some this respiratory infections?
Not
Do you
such a
think it
good
works?
choice. Not such a good choice. I have a slide which I didn't put in my this thing. If you look at the sensitivity pattern to penicillin injectable for strep pneumoniae or strep pyogenes, it is 100%, literally. So it has to work. For strep pyogenes, it's 100%. For strep pneumoniae, it's over 95%. For penicillin, oral penicillin, it is only 53%. Now it's the same molecule, but what is happening is that stomach acid destroys it. And therefore, I am not sure whether oral penicillin will work. So as I said, if you have a acid-resistant penicillin, you can use. But amoxicillin, although is also still labile to stomach acid, is still much more resistant than penicillin G. And therefore, I would prefer to use oral amoxicillin and not pentates.
Any more questions?
Yes, I want to just suggest one thing. Sir, you have done an excellent work as a chairman of the pediatric COVID task force. So probably you are much more come in the relation with the Maharashtra and the agencies. So why is that so many irrational combinations are flooding the market? When we speak of DCGI, we come to the this quinolones, but why we are not forced and can be enforced the DCGI to take the lead and to stop ban the production of this molecule itself? Because though we as a pediatrician, we will try to learn and rationalize ourselves, but it is much more rampant at the general practitioner. We are not blaming them. We are also equally responsible, but it is much more rampant because I have seen the mode of the MRs, how when they go to general practice, they speak there. Because when they show cefizime can be used in respiratory infection, I say, please don't tell me this. But they are very clever enough to hide that this folder and that, but they should do the general practice. So the question is, whether not question but suggestion, sir, because we have worked with so many, whether it can be done by IAP to just stop this production of through DCGI.
Okay, I'll answer that question in brief. I know we're nearing 10:15. Soon our host will say stop. Okay, first point is the DCGI is a central body. My relationship has been with our Honorable Chief Minister, and I have no control with what the Delhi government does. I have no contacts there. But at the same time, I must tell you that in 2014, the IAP opened a dialogue with the central government. And Dr. Yevle that time was the chairman, the president of the Indian Academy of Pediatrics. He took the initiative. We had several meetings in Delhi. I was part of the delegation. We had 2 or 3 meetings in Delhi. We flew to Delhi and we discussed with the government how we can curb irrational antibiotic use. And even the secretaries and ICMR was part of this. We had representatives from WHO and UNICEF. And everybody agreed that needs to be done. The government promulgated an ordinance, I believe it was in 2016 March, which banned 344 antibiotic combinations which are available in this country. And a few weeks later, the pharmaceuticals approached the Supreme Court, and the Supreme Court struck this order down. Now you see what can be done now. We have made the effort. The government has also cooperated. The ordinance was promulgated, but I don't know where to go. I am sure I am aware that this is being recorded, so I dare not voice what is actually going on. I will be held for contempt of court. But there are a lot of issues that arise. The pharma industry is very powerful. It is very rich, so they can manipulate things. I will not say anything more.
Then there is the only option to file an PIL.
It goes to the same court, sir.
Yes. Yes. Yes,
So one last question from my side.
So the one answer which was given about during one of the conference by Dr. Amdekar sir. When we stop the production of that drug, will stop. For example, Nimesulide is a live example. When we stopped using, everything was stopped. But it is not working, so because 1 or 2 is much more irrational. That ofloxacin and metronidazole, that is very rampant. At least that some of the drugs should be stopped. What I feel.
Okay.
Yes.
Yes, Dr. Lakshmi had a question.
Yes.
Last question, I
So
think.
We use de-escalation therapy in ICU.
Yes.
What would you recommend for de-escalation therapy for oral antibiotic in OPD practice?
You don't escalate at all, so there is no de-escalation. You have to start low and escalate. That's what you do in OPD practice. There is no de-escalation.
That is it. Thank you, sir.
Okay.
And okay. I'm very much thankful for the President, sir, and Secretary, sir, for giving me the privilege to moderate this session. I must say, the father of infectious diseases in our era,
No, no.
Dr. Subhash Prabhu, sir. No, sir, that is the truth. Thank you, sir. Thank you very much. Over to Dr. Amol Pawar, sir.
I'm here to say a vote of thanks. Thank you, Subhash Prabhu, sir, for very important, for very informative talk on this common infectious disease and rational use of antibiotics in this disease. I hope after hearing all these rational protocols in using antibiotics, lot of practitioners will think twice before writing antibiotic.
Only
and
5.
Thereby,
5. Amol say
and
5
thereby,
antibiotics. Name
yes,
them.
5. And thereby it will reduce the antibiotic resistance. I also thank Dr. Lakshmi for moderating this very informative, very important session. I also thank all panelists and all practitioners, pediatricians who have joined for today's MAHA-AP webinar. Thank you once again to all. Good night.